Now try it.
Oh, let's see. You can't start your video because, no, it's still saying same thing. I'll leave because see if I can come back in again. It's weird.
Okay, now we see each other. That's great. And if I wanted to try to share my screen, I have that option. Good. Now let me choose the.
Oh, it's a pretty fall background.
Yeah, it's actually from last year. What happens to be just relevant right now as well? Where am I? Okay, here. All right, webinar. So I have what is it? 13 slides, which is a very lucky number. With the last and the first are just kind of the title and acknowledgement. So yeah. Okay. So you tell me when I should start, and then.
Okay. We will get started right at probably like 3:03. Maybe just wait a few minutes for people to join.
Now, you might see our pictures as well, right? Your picture and my face.
Yeah, I can see your face and the picture.
You see my slides also?
Yep, I see your slides.
Maybe I should make sure that I show only the slides, or maybe we just keep it to the.
Yeah, your face is just small off to the side. You mainly see the slides.
Okay, good. So none of the slide is covered up, because on my screen it's covered up.
Good.
And
is it covered up for you?
No, I actually made it like a thumbnail or whatever that's called, and underneath the slide, so I see.
I can see the screen.
Okay, great. Thank you.
Hi, Anna.
Hi, Dr. Paul. How are you?
Good. Great hearing your voices. Well, I mean, I saw actually Stacy, but I didn't see you. And so
I know.
Yeah, it's because of I must have set something up incorrectly, which is surprising, but it happens.
Pretty good. I think we'll be fine.
I'm going to turn my camera off when you start presenting, Dr. Szabolcs, just so people can be focused on your presentation and not my face.
So hopefully I'll
but I will do introductions.
Okay.
So we'll start here in about
and then
3 minutes.
We'll see folks who log in and might be asking questions.
Correct.
Super.
And it's being recorded, which is even more important, so families and clinicians can get the information from our website.
Okay.
Folks, we'll wait just a few more minutes. There are a few people just still jumping on. So we'll wait 2 more minutes and then I will go ahead and introduce Dr. Paul Szabolcs. Thank you for your patience. All right, everyone. I'm Stacy Pike Langenfeld, president and co-founder of Krabbe Connect, and I thank you so much for joining us today for this important webinar. I also want Anne Rugari to have an opportunity to introduce herself, and I will let her do so at this time.
Hello, I'm Anne Rugari, co-founder and vice president of Krabbe Connect. Welcome, everyone.
We want to take this time to dive into reduced conditioning for bone marrow transplant, and Dr. Paul Szabolcs is closely tied to this research and work being done in this space. Early in his career as a specialist in blood and bone marrow transplantation, Dr. Paul Szabolcs saw many patients with life-threatening illnesses for whom a transplant might be curative, but were turned away because they were deemed too sick to withstand the intense chemotherapy needed to prepare their bodies for the transplant. So he asked himself whether it was necessary for every patient to receive such intense chemotherapy. He recalls he could use reduced conditioning for pre-transplant chemotherapy, and many more patients might benefit from this therapy. And since this, about a decade ago, he has dedicated his career to devoting time towards this reduced intensity chemotherapy regimen. And we are so excited today to listen to the new information that has come out around this idea. Dr. Paul Szabolcs has a obviously lengthy CV, which we won't go into. So with that, and further ado, I want to turn it over to Dr. Paul Szabolcs, who is going to walk us through what this regimen means and what it can mean for patients impacted by Krabbe disease. Thank you so much, Paul.
Great. Well, thank you so much, Stacy and Anne, for the invitation. And it's absolutely a pleasure and honor to join you and the families who might be following this. So you see my slide up there that in the background is Children's Hospital of Pittsburgh. And it is actually a rather green city. And I've been here now with Maria Escolar, who's my wife, and it's an conflict of interest, maybe of some sort, for almost 11 years. And I do have a conflict of interest as Maria and I are co-inventors, and we hold equity in a biotech company called Forge Biologicals and Soteria, which is specifically focusing on Krabbe disease. So moving the slide forward, the indications of hematopoietic stem cell transplant. So HSCT is an abbreviation for really a transplant that's coming from the bone marrow cells and restoring the bone marrow cells, blood cells, immune system. Has a long history, and obviously we are focusing on anything other than cancer, so we call it non-malignant diseases. And then if you look at this big group of diseases, we can split it into 4 major categories, and our focus is on metabolic disorders, and of those, leukodystrophies, where Krabbe disease is unfortunately one of the ones that families have to face regardless of ethnic background, as we have seen over the years. So clearly different history and different way of mechanism, because the first 3 categories, the disease actually hits the bone marrow cells, white cells or red cells or lymphocytes, which are a type of white cells. So you could consider stem cell transplant curative. For metabolic disorders, unfortunately, we are unable to achieve cure. The mechanism is through healthy white cells now carrying typically the missing enzyme and transporting it to different part of the body, is most importantly to the brain in these diseases. So Krabbe disease is obviously our major focus, but I was asked to talk about the technology here, how we can bring a safer approach to children and potentially extend it to even those with some involvement already. So the most commonly used graft is cord blood graft. This is just showing the placenta. Some of it is actually betadine, so it's not that grossly bloody, just really to make it sterile. And the placenta is on a shelf hanging, and they drain it by gravity into a bag. And then after some centrifugation steps, the volume that's typically about 4 ounces can be concentrated into about 3 ounces. And that's how it's frozen. So it's really important because there are public and private banks. So the public banks basically provide the cord blood unit for families other than where the baby was born. And we really placed a huge effort on making it the fastest here in Pittsburgh between a potential patient and starting conditioning. So really we can, from a first meeting, get started within the first 2 weeks with a patient. And the key thing is to have the cord blood unit, the final chosen cord blood unit, arrive by the time of the higher dose chemotherapy. So this is the history, and it goes back to 1991, New York. And by now, in the 21st century, we have over 600,000 units frozen, which is still far fewer than the living unrelated donors, but we know that we can afford some mismatches. So really, well over 95% of children, regardless of their ethnic background, will have a suitable unit. And really, if I look back in these last 11 years in Pittsburgh, not a single child who was eligible for stem cell transplant is that we had to say, no, we can't find a cord blood unit. If there's a perfectly matched living unrelated donor or a matched sibling, we might consider that for a juvenile or late onset disease. So it's not just that cord blood is that we do. We are strong believers that every patient deserves, the best unit we can find. And we match it to the disease phenotype, with the early infantile ones obviously very rapidly progressing. So here the cord blood is a ready-made source. So I'm tasked to talk about reduced intensity. So we compare it to something, and the something is the historical myeloablative conditioning, the maximum intensity that was developed really for leukemia in the 1970s, 80s. And then since it worked, it was introduced by Dr. Krabbe and then Dr. Kurzberg and others, basically with the same intensity for Krabbe and other diseases. So as you can see, these are survivor curves. So at the time 0, 100%, 1.0 is alive. And then with the different colors, you can see the different diseases. So this was a paper representing an era where I was part at Duke in the early 2000s. And you can see really that regardless of the disease, whether it's Krabbe or metachromatic leukodystrophy or Hurler and so on, there's a steep drop in the first few months. And that's really what we call transplant-related mortality. And even much later, when the Dutch, Polenz and his group with the London group presented their data with somewhat different population, they also had the same very steep drop. And clearly, we are responsible transplanters for losing patients early on. And whether it's called GVH or infection or end organ, multi-organ toxicity, it's something that really prevents us to really evaluate the benefits of transplant.
Dr. Szabolcs, we had a question around, is it
Yes.
okay if I interrupt you
Yes.
during the,
Yes.
one of the questions is a 7 out of 8 a good match for a transplant? And what is the percentage of the child to accept it and not having gross versus host afterwards?
Right. So the 7 of 8 in cord blood is outstanding. For unrelated bone marrow, we consider it fine. It will always depend on how the transplant is done. So if there was no ATG or Campath, these are agents used, then both GVH and rejection would be somewhat higher in risk. And then not only the use of these drugs, again, Campath or ATG, will address it, but the dose and timing. So unfortunately, the answer is not that simple. One would need to look at the specific kind of conditioning regimen being offered, and then I would be able to have a better, answer. So as you will see in our slide, the way we do it, we think that we find, not just think, but we find that the rejection is less than 5%. And we'll talk about GVH as well. So that was a very important question, and I'm sure that similar ones will follow towards the end. And I have altogether 12 slides, so we are probably at the third or so fourth. So the reasons for the reduced intensity regimen is listed here. So overall survival should improve. I don't find it acceptable to have 70, 80, or anything less than 90% survival. And then eventually we want to talk about event-free survival, which means that you didn't have to repeat the transplant because a second transplant is already an event. And as we earlier talked about, the rationale, the 2 sick patients should be brought, and when they go through transplant, it should be a little bit less playing with fatal possibilities. And there are various toxicities that I listed, and I don't want to read it through, but just one example, for instance, draining fluid around the heart was up to 1 in 4 babies that was necessary with the maximum intensity. And as you can imagine, that's a pretty aggressive intervention. And then even more fatal events like bleeding into the lungs and other things may occur. And then just as important question is, could we, by reducing the intensity of the chemo, could we reap long-term benefits, which is growth, and then some endocrine side effects, and potentially reduce chemo-induced secondary cancers that is otherwise known to happen, and typically more like 10 plus, 20 plus years after the transplant. So before we go, again, I just wanted to clarify, the word reduced intensity basically means everything less than the maximum. So as you see on this slide, at the triangle pointing upwards, the base is the maximum intensity, and then nil, nothing, is the tip of that triangle. So I put an arrow where I believe we are somewhere with what we call the RIC, so the Pittsburgh Reduced Intensity Conditioning. So RIC stands for Pittsburgh Reduced Intensity Conditioning. And so basically it's a shade of gray, and there are multiple shades of gray, and that's why one RIC regimen may not be sufficiently strong enough. And that has been seen with some fludarabine busulfan with ATG combination regimens where rejection was high enough to need 10, 20%, over 10% of patients needing repeat transplants. So I think that's the key takeaway here, is that, let's say, our reduced intensity may be different than in other centers. And historically, for instance, Cincinnati Children's and London were pioneers of the same 2 agents, same 3 agents, Campath, fludarabine, melphalan, that we use, but we also added thiatepa plus hydroxyurea, making the RIC probably a tiny bit more intense, but at the same time, quite a bit more effective to reduce rejection. So next slide. So we did this in a prospective trial, which is very important because sometimes people just look back and say, okay, well, we did this and that, and let's present it. But here it's really, we set out to conduct a trial and report consecutive cases in the way they are. And we realized that these are rare diseases, and we thought that we might be able to put together a regimen that could be utilized for multiple diseases. So here we have 76 patients, and probably by now maybe even 80, where the age actually now, I'm sorry for the top, it's not 34 but 50 years. There was a 50-year-old gentleman with metachromatic leukodystrophy who came from Tennessee, So really, it's widely used, and obviously, we are not using a tiny cord blood for a big 50-year-old, and his late onset MLD was permissive to wait until a well-matched unrelated donor we brought in for bone marrow transplant. But the numbers are correct for Krabbe. So 19 were the most common disease was indeed Krabbe disease, and they were infantile or late infantile, occasional juvenile onset. And MLD, metachromatic leukodystrophy, was the second most common. And there's a smattering of all kinds of inborn errors. Some of them are immune diseases like DiGeorge or XLP, IPEC syndrome, and some of them were diseases of the bone marrow like sickle cell, thalassemia, congenital dyserythropoietic anemia. Let me move the slide, excuse me. All right, so this would be the engraftment kinetics. So day 0 is when we infuse the cord blood, and I'm going to be focusing on cord blood because in children, that's really, out of the 76, as I said, over 50 were cord blood recipients. And so the engraftment percentage, so at day 0, nobody's engrafted. So we start from 0, and the neutrophil is the blue one. As you can see, everybody engrafted. And that's for the neutrophils, followed by platelets. And platelets come 2 different time points in terms of the minimum to prevent bleeding, 20,000, and a more robust number, 50,000, where, you know, if you fall, you may not get bruising. Out of the 52 patients, there were 2 patients who then eventually had secondary graft failure, which means that donor cells came in, but then their own cells recovered. So these 2 patients successfully were retransplanted with another reduced intensity regimen. They were not Krabbe patients. And then we follow what we call donor cell chimerism. So fractionate in the blood and ask how many cells are out of 100 donor as opposed to the host. And at the very beginning, it's uniformly close to 100%. Much later time point, it may dwindle a little bit with some host cells recover since we are not using maximum intensity. And that actually is a safety valve, I believe. So with those 2 patients who rejected, their own cells recovered. So they were not vulnerable for infections with no white cells around. So here is the key thing, the survival. It's the first 1 year, and at 1 year we have 95% overall survivor, and the event-free survival means is again acknowledging the retransplant as a failure, even though they are alive. And as you can see, these patients who passed away, and they were back in 2013, had early onset viral disease. And since then, we have instituted more aggressive monitoring and also some antiviral T-cell therapy that we can manufacture here in our center for aggressive onset viruses. And then there were 3 patients who died of progression of their underlying disease. Sadly, some families with different, not Krabbe, other leukodystrophy, kind of didn't have the full support of the child. So there was one who was actually withdrawn from nutrition and some other events. So what we can find, and I'm sorry, the title somehow fell out of the slide. This is as a summary slide. We have an overall consistent 95 to 96% engraftment with a single unit cord blood or bone marrow. And overall, we've done 23 patients for Krabbe disease in Pittsburgh. All of them are alive, thankfully, with donor cells. 19 were in this particular clinical trial, and there were 4 infants who were less than 3 months old. And for those, we do not offer thiotepa because of concern of maybe too much CNS irritation. And that was a key aspect of designing. So they were thiotepa-free, reduced intensity regimens. And that's what we would offer for any newborn baby, let's say, coming here. So our finding is that at 1 year is really the transplant-related mortality, or mortality is less than 5%. And we have the inborn errors, that's IEMs, with normal enzyme level, even if they have mixed. So some host cells recover. And it's well tolerated, we believe, at least comparably to the old myeloablative regimen. And we have not seen veno-occlusive disease except one. So the majority, so with 1 out of 50, absolutely nobody had pulmonary hemorrhage, bleeding into the lungs. They don't have bleeding into the urine with associated pain, no pericardial effusion, nobody had to have drainage put into around the heart, and everybody had a preserved renal function. I didn't show the GVH slide, I was trying to be short. Roughly about 35–40% would develop a graft versus host disease that may need prednisone temporarily, and about 11%, so let's say 10%, which would be the severe grade 3, where the patient would need to stay in the hospital, be admitted for diarrhea and got GVH. But we have not lost anyone of graft versus host disease. All of them have been successfully treated. And nobody had the extensive chronic GVHD, which means that you are stuck with prednisone for a year or two, or associated drugs like cyclosporine or tacrolimus. We can let these patients return home earlier. I think over 26 states, or maybe even closer to 30, that we have had patients come for transplant. So most of them are from out of state. And our goal is to return home by about 6 months. The NDRD program would perform another major developmental assessment at 3 months and 6 months before we would hopefully let them return home. And at that point, if all goes well, they would be tapering their tacrolimus, FK506, or cyclosporine, one of the two. And that can be completed at home with us having telemedicine or just phone follow-ups. And we follow them long term. So where is the future? Again, the title interestingly fell off on all these slides. So the future is potentially more than what's on the slide, but at least these are the immediate ones that I think is on everybody's mind, and that's gene therapy. Gene therapy for Krabbe disease would come with adeno-associated virus, AAV. So there are 2 company-sponsored trials available. One is the one that Maria and I have associated with Soteria Forge. The key thing here is we combine cord blood transplant and the gene therapy. There are some immunological benefits of cord blood transplant. The most simple way to think about it is that since we bring in already healthy galactocerebrosidase containing cells into the body in the new immune system itself, when they meet AAV and more of the galactocerebrosidase, there will be no immune rejection towards them. And immune rejection towards enzyme replacement therapy, or even AAV by itself, has been very well documented for many other diseases. They call them neutralizing antibody or some other ways, but clearly it is the body's rejection of something that unfortunately they don't have. So we believe that there's benefits, and animal models in mice and dogs have shown it by others, that transplant followed by gene therapy might have this synergistic effect. And clearly, bone marrow and cord blood transplant will have said, weaknesses or limitations, most notably as the infants start growing through toddler and then most subsequent years with a lot of limb growth, the peripheral nerves are just not getting sufficient enzyme from the cord blood cells or bone marrow cells, even if you're 100% donor with absolutely normal enzyme level in the blood. And so the peripheral nerves is really a limitation, where clearly the AAV, especially intravenously, as the Forge trial will show, is he able to bring the AAV, which is an adeno-associated virus, but it's not adenovirus itself, and it cannot itself proliferate. It's crippled, genetically modified, can infect the dorsal root ganglia and peripheral nerve cells, so it can overexpress it. So based on animal models, these dogs and mice will have much better gait and normal gait even, and that's the hope with the human trial. So the first patient is actually being treated right now here in Pittsburgh. So it's through intravenous catheter a few weeks after the cord blood transplant, and the eligible age would be right away after birth. And then the other trial that's open currently, that's called Passage Bio, that company that's without the stem cell transplant. So it would face the possibility of immune rejection, but either way still something that patients could benefit from, clearly. And the eligible age is the first cohort at 4 months. I think if they had a couple of successful or at least safe cases, they would decrease the eligible age group. But currently it's open at one site, I think in New York. And that's not intravenous, but it would be injected by a neurosurgeon to a spinal fluid containing space in our back of our head, called the cisterna magna. And Soteria Forge, again, the Forge group is working on another trial that would be also without direct transplant linking, but would permit patients who have had transplant in the past to top it off with this AAV approach. So I would stop here and give an opportunity to be more interactive, and hopefully I could address some of your questions.
Yes,
Stop
there's
the
been some
share.
questions, Dr. Szabolcs. One that's come up: how long after a transplant could a child be considered to be eligible for genetic therapy if transplantation is successful, and if the child is over 2 years old with transplantation outside of US?
So what I understand, the Forge group with Maria Escolar, who is my wife again, so I'm related, is working on this, and it will be available internationally, Europe, but other spaces as well. And having had previous transplant is no problem whatsoever.
Great. Dr. Szabolcs, you talked about 2 patients being retransplanted. Were they, when they were retransplanted, was the same conditioning, the reduced conditioning used, or did they have to utilize the higher toxicity levels?
Very important. So it was also reduced intensity, not with the same drugs. So you could reduce the intensity of any drug. That reduced intensity just means that it's less than the maximum tolerated or maximally used, which again has been typically pioneered in leukemia. So it's not, again, so theoretically any drug could be used as long as it's effective. So the major ones are busulfan. Now there's a new one called triosulfan, and then the melphalan thiotepa combination. So in our case, if they fail the flu-mel thiotepa combination, these two, then they got a reduced busulfan dose, and that's what was given and tolerated very well.
You noted that the patients with reduced conditioning spend on average approximately 6 to 9 months before they get to return home. Is that significantly shorter than the regular conditioning, or what does that look like?
Yeah, so I mean, we have also let, if you get a bone marrow, you might even return in 3 months. I would want to keep here patients typically until 3 months, but with bone marrow, we've done it even to the West Coast. Still with if there's a matched sibling who is not even a carrier, I'm not going to say that cord blood is the only thing that's appropriate. And so we have had, as I said, as early as 3 months, but by 6 months, I'm asking myself, why are we not able to do this? And the 9 months is more likely someone who have had some graft versus host disease or other complication that that makes me not 100% yet comfortable. How much shorter is it? I would say this is about 3 to 6 months earlier than with a myeloablative transplant, typically.
Okay, great, that's helpful. Do you know if there is any discussion in the works regarding a head-to-head comparison study with regards to regular BMT and reduce?
Yeah, so I mean, I'm not sure that anybody is planning a randomized or a trial where it would be randomized. And so clearly, as I indicated, you could reduce the intensity of any drug. So for instance, now there's more and more busulfan without cyclophosphamide called Flu-Bu being used. Typically, it's still myeloablative, but it's reduced compared to Bucy. So they have less complications of organ toxicity, but a little bit more rejection. Now they can successfully retransplant them. So the overall survival is getting closer to where we are. I think for leukodystrophies, I'm not aware that they would have where we are. You know, as I said, our overall survival is 95%. I think in leukodystrophies are typically in the 80s, what I've read. In Hurler, I know that there have been reports stating that they have hit the 90% survival. And again, the question will be the retransplant rate. So that's what we call the event-free survival. So when you ask about event-free survival, failure is death and failure is second transplant.
Is second transplant also something that they consider doing in the regular myeloablating BMT?
Yes,
or is...
so that's much riskier, especially if you have no cells grow back, because your donor cells didn't take, but the host with the myeloablative didn't come back. So it's just a far riskier proposition. It can be done successfully, so it's not that it's hopeless. It's absolutely worth doing. But it's just a whole lot riskier approach, and I don't think the success rate is 100% with a retransplant, or 95. I don't think it's a 95% success with the retransplant. So then it will really drop to, you know, hopefully 2 out of 3 will be successful, or 3 out of 4. So for instance, just again to emphasize, for the newborn Krabbe patients, so who are less than 3 months old, including in this trial, we are using also a busulfan-based regimen. It's just we reduced it, not the same way as some other centers. So that's why the drug names are relevant, but it's eventually a package, and the timing and the dosing is extremely important. We give busulfan only for 3 days, not 4 days, for instance. So that's I can tell you that's already by itself a 25% reduction.
Dr. Szabolcs, you've shown that the reduced conditioning is much better for the patient. So can you see that becoming more of a standard of care in transplant, using this universally, that other facilities may follow these protocols? What do you see for the future of this?
That's a great question, Anne. So I know colleagues in the United States who asked me if I would share, and obviously we published last year where we were very, very detailed, and I know it's been done in Brazil already successfully, and in Europe I'm aware of being done successfully, both Germany just recently, Switzerland and Hungary that I specifically know of, and I think in England they will also. So again, I think it's spreading. This is the campath flumet thiotepa. I think the concept is more important. I'm not, I don't care whether you use exactly the Pitric regimen or a similarly reduced intensity, let's say busulfan, if that's what a center likes. So I think the concept of reduced intensity is spreading, whether or not certain groups who are married emotionally or whatever reason to the myeloablative. I think the concept of reduced intensity or reduced toxicity is clearly spreading without question.
Another question I have is, and I may have missed it in the slides, but what is the oldest patient living with the reduced conditioning?
What is the quality of life of the patients?
Or how long, how old, when was the first year you did?
Oh, yeah, 2011. So yeah, I mean, behind me, this little pumpkin is now 11 years old. Yeah, and back in North Carolina at Duke, I started a trial. It was limited. I was not permitted to take patients without severe either mental retardation or neurocognitive decline. So they were not, they were really the sickest of all. So we have some going back now. I think that trial I started with Dr. Parikh, 2008. So that, there are some patients who are, I guess now 13, 14 years out. I know for Hunter syndrome and I think there's metachromatic leukodystrophy. I don't remember off the cuff Krabbe in that group, but I think that was one.
Dr. Szabolcs, what's the biggest benefit you're seeing from the reduced conditioning since 2011 in these patients when they do return for possible visits? What is
That's a great question. I think I'm most delighted when I hear from NDRD, from Maria Escolar, that they can tell if a patient got reduced intensity or not. I mean, the depth and detail of their assessment is obviously far different than mine. And they obviously have these very delicate, detailed studies. So clearly they are just more fit, less moribund, or especially early on. I think it's striking in the first year. Since we don't have extensive chronic GVH, you don't see our patients all puffy, the prednisone Cushingoid face, Michelin boy appearance. I mean, that's just an early one. So I think, again, they are less beaten up. I mean, it's not a nice phrase. I apologize for that. And again, we are not giving maple syrup either. It's still chemo. They still lose their hair. The babies typically go on total parental nutrition, but we are able to discharge them 4 or 5 weeks after transplant, and some of them, especially the older ones, are able to eat even through transplant a little bit. But again, we don't have to drain their fluid around the heart, and we don't deal with some of those really extreme complications. So intensive care, we haven't done much of that, to assess the number of ICU days. But again, we took some patients that other patients wouldn't accept, especially like a 5-month-old early infantile Krabbe, where obviously we have to be very careful what benefits we may bring. So that's really, again, not my primary responsibility. It's NDRD with Maria and her team, which prepares, and we reinforce that we are preserving vision, we are preserving social interactions, social smile, and an interaction. Really, we are not proposing that this baby is going to be, walking or even sitting independently necessarily. So that's a choice that the family can make, and their quality of life is still improved in the sense they don't have that miserable, painful cry. So that's one of, it's very funny how as a pediatrician, I don't like children crying. So we don't hear that. It's really nice that they are at peace, and so many of you sadly know what it is when these kids are just hyper irritable. So there are these quality of life benefits that we are, if the family is willing to take on that journey, because it's still, again, the child is going to be disabled, and it's a huge commitment. We might consider, but obviously there are some families where either we think it's not worth the risk, or the families say that thank you, but no thank you.
Great, thank you, sir, that. And did you have a comment?
I just had another question, but I'm sorry. The other question I have was in the patient that was older, in their 50s. How did that patient fare, with their progression of their disease?
No, that's great. And actually, I am thrilled and so grateful to Pittsburgh Children's that we are bringing a 50-year-old to a children's hospital. And it's a freestanding children's hospital. We are not attached to the adults. So it was obviously a lot of effort on my end and my colleagues to develop ties to the adult hospital. So they go to the adult hospital called Presby Montefiore, 3 miles down, where they get pulmonary and cardiac evaluation, and we have telemedicine, and they can come over and whatnot. We are thrilled. And actually, these are kind of exciting. The disease is very different. They sadly are diagnosed not because they are necessarily stumbling or weak, but because their personality changed. And the very first one was a 44-year-old from Kansas, also with metachromatic leukodystrophy. So we have now several years follow-up on the 44-year-old, easily 4 years. But even the 50-year-old who is just 1 year and a few months, he returned home in 4 months. It was during COVID time, so it was plenty stressful. And he's sharper, I think. He's able to reflect. He walks, he does things. He helps around the house. So you wouldn't necessarily think there's much wrong with him unless you get really deep conversation. He was a nurse, poor thing. He lost his job before the diagnosis was made because he was not a responsible person anymore. They somewhat lose our, not sure what's the right phrase there. We have our inhibition of what's appropriate to say, what's not appropriate to say. And so he was very talkative and not always appropriate necessarily. So personality changes, and many of these things are improving. In the 44-year-old, we can tell, even bone marrow transplanters, that she's much more together. She's able to talk about her detail the day, how she can do something but not other things, what she can remember, what she cannot remember. So they are actually really exciting. We are right now with someone who's in his 30s with Krabbe disease, going through assessment, and this week he already has wheelchair use and some other challenges. Dealing as an adult with skills lost is different. So that's going to be our first potentially adult Krabbe, and I think this is where Krabbe and MLD separate, because the other adult Krabbe patient that I'm aware of and personally seen, age 30 plus, was also severely weakened already. So with MLD, it looks more like a brain disease in their 30s, 40s, as opposed to muscle strength, coordination. With Krabbe, adult Krabbe, once you are in your 30s, there's significant weakness. So I think stoppage and potential improvement is realistic. And there was a report way back in England also of a single case adult onset Krabbe. So I think addressing these folks is very important, and I'm excited if we have the opportunity. And they have all done well. we always found either 8 of 8 or 7 of 8 bone marrow. And we are more than happy to do the 7 of 8 bone marrow with the exact same regimen that we are using for the cord blood kids.
A question just came in, Dr. Szabolcs. What is the possibility of a child being rejected for a transplant? How much of Krabbe disease damage is too much for a child to be considered for a transplant?
No, it's a great question. We haven't had too many of them. That screening is really done by Maria Escobar and her team, Deepa Rajan now as another physician joining the team. I think if it was, let's say, a less than 1 year old and they are already gagging, they are not able to handle their secretions, I think that, or having seizures, I think that would be something clearly. Otherwise, it's really a conversation, and I think that's where NDRD does a great job in having from their enormous database of natural history pull out similar cases to every new family to project the trajectory of the transplanted or untransplanted one, and then engage in a conversation. Is this something that they are interested or not? So we have had patients, not with Krabbe, that the family decided not to come for transplant, even though we thought would be a reasonable thing and would provide measurable benefits. But still, the 6 months relocation, if you come from Colorado or wherever far away, I'm not going to promise you less than that. There are some occasions when we have, and we have now a lot of partners in other states. So again, if things go amazing at month 3, 4, then maybe we can work it out that you leave at 5 months. So I'm not, nothing is written in stone. But interestingly, we had an adult Krabbe patient who I thought was a great candidate. Maria thought was a great candidate, but the patient just didn't think it was worth the relocation and all that hassle and discomfort. So the adult decided against it, the patient himself. And we respect it, obviously.
Great, thank you. I don't think there's any more questions. I'm just going to wait a minute here, Dr. Szabolcs, to see if anything else comes in. But I do want to thank you for your time and being with us this afternoon.
Well, thank you for the opportunity to work with the community, and it's something very special for us. And we are here to help, and we hope we can help, and we recognize that, we have room to improve, and that's why it's an exciting time. I think hopefully the next year or two will unveil the full potential of these additional combination therapies.
Appreciate it. Thank you, Dr. Szabolcs. This will be up on the website soon, and we'll be sharing it out to the rest who couldn't make it today. Take care, and we'll be in touch. Thank you.
Thank you. Thank you again.
Bye-bye.